Hi guys, this is Alicia with Good Morning Sunshine. So I'm a bit under the weather. Currently I think have a cold, but I'm gonna try to get through these lectures. I'm gonna do 3 of them at least. I know we have 4. One's bacteriology though, which I haven't talked about, so I may not do that one. But I'm gonna start with pharmacology. So we got into resistance of the antiparasitic drugs. So this is an increasing problem. So it significantly reduces ability to control these parasites. If parasites are resistant to a member of a drug group, assume they are resistant to all members of that group. So we group drugs in different ways, but yeah, if they're resistant to one of those drugs in that class, basically, they're going to be resistant to all of those. So what is resistance exactly? Well, it's when a greater frequency of individuals in a parasite population, usually affected by a dose or concentration of compound, are no longer affected. Or a greater concentration of drug is required to reach a certain level of efficacy. So in other words, it's used to work and then it doesn't work. Resistance to antiparasitic drugs. Resistance is a heritable characteristic. It results from random mutation always going on in a population. So we assume little or no advantage in the absence of the drug, so low frequency in population. The drug use selects for resistant alleles and increases their frequency in the population. The resistant mechanisms vary. And then, so what's different about resistance in multicellular organisms? Well, he made this joke about if you don't have money, the next greatest thing is sex. So that's the answer to what's different about resistance in multicellular organisms. Sex. So example, it's a single gene. So we brought back genetics. So capital R and R. So we have a homozygous dominant, which is RR, capital RR, which are susceptible. And then we have lowercase rr, which are homozygous recessive. They're resistant. And then we have heterozygous, which of course is capital R and R. So let's assume it has advantage here. So of course they brought in the Punnett square again. So we have 25% that are homozygous dominant. We have 25% that are homozygous recessive, and then we have 50% that are heterozygous here. And then the proportion of resistant worms in the population increases following repeated drug use and removal of the little r alleles from the population. So this is a normal distribution curve, which normally never happens. So then it's moved and there's higher resistance to the drug now. So it goes from a normal distribution curve and then it moves over. It keeps moving over until little r is removed. So when homozygous recessive gets removed. So the proportion of resistant worms in the population increases following repeated drug use and the removal of the little r alleles from the population, like I just said. So what does drug resistant look like? So here, when we first gave the drug, time 1, it was 98% effective. For time 4, it's 70% effective. And we gave it 8 times, it was then 30% effective. And then by time 12, it's 15% effective. And if we knew this, we should have stopped once we saw that I hit 70% my voice is probably going to go out at some point, but so when it reaches 70% efficacy, we should have known that there was becoming resistant to the drug. So we need to learn to stop it until it gets to like time 12, because then it's too late. So anthelmintic resistance, problem worse in grazing animals. So the contributing factors here is animals eat where they defecate. They're kept in groups. The prevalent approach has been to deworm to prevent any possible problem with developing widespread use of porons in cattle. And the more often the drug is used, the faster the resistance is developed. So factors affecting rate of development of resistance, starting with an effective drug. We were given scenarios and we were supposed to choose which scenario would increase the proportion of resistant alleles more rapidly. So here's our chart. So we have scenario 1 and scenario 2. Number 1. So we were given deworm horses 2 times per year or deworm horses 6 times per year. So the question is, which scenario would increase the proportion of resistant alleles more rapidly? So this would be scenario 2, would increase the proportion of resistance alleles more rapidly. The deworming of horses 6 times per year. Second, we have deworm sheep and move them to pasture previously used for crops. And then we have deworm sheep and move them to pasture previously used for unrelated sheep. So scenario 1 here would increase the proportion of resistance alleles more rapidly. So then we were given a group of pigs weigh 40 to 100 pounds, treat all for the weight of 70 pounds, or a group of pigs weigh 40 to 100 pounds, we treat for weight of 100 pounds. Here it would be scenario 2, and then the next one was use heartworm preventer before expiration date. We want to do that. We never want to use heartworm preventer after the expiration date, which that was scenario 2 in that case. And then last, we have use oral ivermectin in cattle or use pour-on ivermectin in cattle. So scenario 2 here would increase the proportion of resistant alleles more rapidly. So the use on pour-on ivermectin in cattle. A single dose of the drug given orally. Oh, I just talked about that, sorry. So then we got into this chart, a new chart. So we're going to assume daily exposure to parasites of all genotypes here. So he asked us which drug would be better, drug 1 or drug 2. Here, so drug 1 is this one right here, and then the orange one is drug 2. And then here, drug 1 is better because it has less time in the body, so less time to have resistance to that drug. So managing anthelmintic resistance, drugs used inadvertently selects for resistant parasites. Most use drugs in ways that slow the development of resistance. And one way to slow the accumulation of little r alleles is to obtain some big R alleles, thus reducing the chances of making more double R, lowercase double r individuals. So again, little r being homozygous recessive, meaning resistance. So what if we don't treat all of the animals? So pool of parasites are not exposed to the drug is called refugia. Refugia is the population that is not in contact with the anthelmintic drug. That population will keep susceptible alleles, which will dilute the resistance. These are parasites not exposed to the drug when you give it, so not the resistant ones. This has become one of the most important principles in parasite control, especially for grazing animals. The goal is to dilute resistant genes in the parasite population to delay anthelmintic resistance. So using refugia, don't treat all the animals, just treat the ones that have high counts of parasites. So increased use of target selected treatment contributes to the increase of refugia. It avoids exposing all parasites in animals to a drug treatment. So examples, so herds of horses only deworm individuals with high egg counts. Flock of sheep only deworm anemic ones. So stuff like that. Example, so we have canine heartworm, adults and dogs, several larvae stages in mosquitoes. However, the use of heartworm preventative is widespread. All the preventants are in the same group class. So what is the refugia for heartworm preventive in Blacksburg? That's a question. Apparently he's going to ask on the exam. So we have to think. So not all cats and dogs are on heart guard medication. Also, wild dogs are not protected here. So those all have to do with refugia. There's also other reasons for parasite treatment failures. There's dose too low, there's faulty dosing, there's the wrong drug, animals exposed to overwhelming parasite numbers after treatment with massive reinfection. So we want to test for resistance. With intestinal nematodes, you can compare number of eggs and feces before and after treatment. So you would expect 90% reduction if the animal is not resistant. And then we got into what factors influence the rate of development of resistance. So more often, 90 to 99.99% are non-long dominant. So we treat efficacy, refugia, half-life, genetics. So then less often, less than 90% significant is short recessive. So integral parasite control, or IPC, is critical. Anthelmintics barely work at all in small ruminants anymore. So we would then look at drug combinations, and also rapidly heading that way for horses and maybe cattle. We want to design programs to increase refugia, slow the development of resistance. This requires more methods of parasite control than just the anti-helmintic drugs. Okay, and then we started with virology. So we started now talking about RNA viruses. So we gotta know that most RNA viruses replicate in the cytoplasm. Also, there are positive and negative sense RNA viruses. Positive one uncleaves the capsule, the RNA is exposed, and it takes it to a ribosome and uses it as mRNA. In negative sense, it has to include the enzyme that makes RNA from RNA. So it has to make negative RNA into positive RNA with a positive sense in order to then become messenger RNA. So we got into the order monogaravales. This is a single segment negative sense. All these are enveloped viruses, RNA viruses. They are helical nucleocapsid. Their genome is similar organization. It's a single molecule. It's negative sense. It's single-stranded RNA. The virion is associated with RNA polymerase. It's a single transcription promoter. It buds from plasma membrane at sites containing peplomers. It doesn't survive well in the environment due to being enveloped, of course, and one segment of RNA has a helical symmetry inside the virion. So inside this class, we have the Paramyxoviridae. We're going to get into rinderpest virus. It's the only animal virus that has been globally eradicated. It's not zoonotic. It was in cattle. The signs were diarrhea, erosions, and acute death. But yeah, that one got eradicated. So factors that enabled this eradication included an efficacious vaccine, so it created immunity, reliable diagnostics, and the absence of carrier animals in wildlife reservoirs. So the control of animal movement in this case is the single most important measure for preventing disease transmission, in this case anyways. And then we got into disease affecting bovine mucosa, also known as DABM. So diseases that do this are bovine papillary stomatitis, blue tongue, bovine viral diarrhea virus, foot and mouth disease virus, vesicular stomatitis, and malignant Carterhall fever, and rinderpest, which I just told you about, but that was eradicated. The key concepts of paramyxoviruses, they replicate in the cytoplasm. They have eosinophilic intracytoplasmic inclusions. Libel in the environment. Disinfection is easy. Transmission is by aerosol or close contact. They're single-stranded RNA viruses. The replication is in the respiratory tract. They get spread by inhalation. Virions are released by budding. They produce a fusion protein. Syncytial cell formation is common. The viruses also have a narrow host range. So again, in this Paramyxoviridae class, we have canine distemper virus. Rinderpest has a lot of similarities to distemper virus. Canine distemper also equals canine distemper virus, which also equals paramyxovirus. Feline distemper, however, when people are usually talking about this, they're talking about feline panleukopenia, so feline parvovirus, or just parvovirus in cats. So they're not actually talking about feline distemper. Canine distemper and human measles virus are antigenetically related. So getting into internuclear and intercytoplasmic inclusion bodies, these inclusion bodies in the means they're in the cytoplasm and they're in the nucleus as well. That's what makes them unique. These viruses unique. So we remember that infections with canine distemper virus, which is a paramyxovirus, may produce both internuclear and intercytoplasmic inclusion bodies as seen in this histopathical section of the brain. So the yellow arrow here is the internuclear, the big one, I don't know if you can see it, and the blue ones are the intercytoplasmic. It's highly contagious. It affects many cell types, including epithelial, lymphoid, and oligodendroglial cells and causes generalized infection. It affects the skin, the respiratory, the gastrointestinal and urinary tract, and the brain. The infection occurs between 3 to 6 months when maternal antibody declines. So continuing with canine distemper virus, acute disease is followed by recovery and lifelong immunity or neurological disease and death. Clinical signs include leukopenia, young dog with seizures, diarrhea, vomiting, conjunctivitis, nasal discharge, coughing, and hardening of the nose and foot pads. Old dog encephalitis occurs years after recovery and it results in neurological deterioration and death. Infections can be about subclinical. This is usually in 50% of cases. It could be a mild kennel cough. However, severe generalized leukopenia, anorexia, mucopurulent nasal discharge, conjunctivitis, and depression. Pneumonia or vomiting and watery diarrhea in severe cases. You can also have CNS signs and failure of enamel development of teeth, which is shown here. And then in older dogs, we can have the encephalitis in older dogs and hyperkeratosis, the hard nose. Then we have bovine, PI3, and BRSV. BRSV stands for bovine respiratory syncytial virus. So BRSV used to be known as a paramyxovirus, like I was talking about before. However, it's now put into its new family and is now known as bovine pneumonovirus, or it's in that class now. But BRSV is moderate to severe disease. It affects young calves and older cattle. It's part of the BRD complex, or it was. Vaccines available. Infection immunosuppressive. Its immunity is short-lived, and adults atypical and interstitial pneumonia. So again, it affects beef and dairy cows. It replicates in ciliated epithelial cells of the respiratory tract. It includes syncytia and intercytoplasmic inclusion bodies in the infected cells. So comparing and contrasting, there's a wide range of clinical diseases by paramyxoviruses. Most have some respiratory component. Intercytoplasmic inclusions are common. Syncytial formation is common. Canine distemper virus produces both intercytoplasmic and internuclear inclusions. Canine distemper virus affects respiratory, GI, and urinary tract and the brain. The bovine viruses, so BRSV and PI3, are part of the bovine respiratory disease complex. So PI3 is also known as bovine parainfluenza virus 3, so it's often clinical. It's part of the BRD complex. This can be questionable as well, and the vaccines are available, and its immunity is short-lived. And then we're going to get into Rhabdoviridae, so RNA virus. It looks like a bullet. It's also one segment. This is our rabies virus, so its diameter is 180 by 75 nanometers. It's an envelope, so it doesn't survive good in their environment. Its symmetry is helical. Its transcriptase is positive. Its genome is single-stranded negative sense. It has Negri bodies. These are intercytoplasmic inclusion bodies, and they are looked for if the animal has rabies or not. Dogs are usually euthanized and beheaded if the dog bites someone and doesn't have the rabies vaccine. So we would test for Negri bodies in this case. The rabies virus is more than 90% of human cases are the result of bites from rabid dogs. In developed countries, the control of stray dogs and the use of vaccination programs have significantly reduced human infections. It infects the nervous system of all animals, including humans. Affection is nearly always fatal once symptoms appear. Endemic on all continents except for Australia and Antarctica. Its common diagnostic request is an animal known to have been a human rabid. So if rabies is suspected, the suspect animal must be killed and the brain tissue is collected for testing. So that's the beheading of it. Usually maintained in and transmitted by a particular host, depending on the geographical region. Sylvatic rabies is maintained in raccoons, skunks, bats, and foxes. It enters the peripheral nerve endings. Its limited replication locally in myocytes and other tissues. It's transported to central nervous system by the retrograde axoplasmic flow up to the brain. Clinical signs develop due to the neuronal damage caused by viral replication. Its incubation period is up to 6 months. Clinical course is short, so a few days to weeks. Virus is released at axon terminals, where it infects many non-nervous tissues, including the salivary glands. That's how it's transmitted. The rabies vaccination is a kill virus vaccine. Vaccines for dogs and cats contain inactivated virus genotype 1 and are safe and effective. A vaccina rabies glycoprotein recombinant vaccine has been developed for oral administration to wildlife. And then we're going into vesicular stomatis virus, so the erosion of the tongue and mouth in the United States. This is also part of the diseases affecting the bovine mucosa, like I talked about earlier, the DABM. So species affected by vesicular diseases, there's a few vesicular diseases. There's 4 of them actually, but they affect many different types. So they can affect pigs, sheep, cattle, horses. It just depends on what vesicular disease it is. But vesicular stomatitis virus infects the epithelium of all mammals, including humans. Infection results in vesicular disease, so mucosal vesicles and ulcers, vesicles on the udder and coronary band. Because it mimics other vesicular diseases like foot and mouth disease, VS is a reportable disease. Its transmission is by sandflies, black flies, or direct contact. Vesicular stomatitis is endemic in Central America and in regions of South America and the United States. Subclinical infection is common. Around 10 to 15% of animals in infected herds exhibit clinical signs. Vesicular stomatitis is a zoonotic disease with human clinical signs that resemble influenza. So comparing and contrasting, both viruses have wide host range. Both viruses are endemic in North America. So we're talking about rabies and vesicular stomatitis virus here. Rabies virus infects neurons. Vesicular stomatis virus infects epithelial cells. Rabies is transmitted by saliva and bites, whereas vesicular stomatitis is transmitted by arthropods. Rabies is reported to the health department, whereas vesicular stomatitis is reportable to state and federal veterinarians. Then we ended that one. And then we got into clinical pathology. We're talking about lymphocytosis. So lymphocytes originate from bone marrow. They go to the thymus for further differentiation. And then from there they go to the lymph or the spleen. B cells make their way to the lymphoid tissues. They have short-term and memory cells. Secondary lymphoid tissues, there are T cells and B cells. The T lymphocyte cells make their way into circulation. They make a circuit for lymphoid tissue to blood and back. They are very long-lived. So getting into lymphocyte kinetics, here we have a picture, and I'm going to talk about this picture. So capillaries progress to post-capillary venules. Most cells remain in the lumen space or luminal space. There is some plasma fluid and lymphocytes that reside in the interstitial space. Lymphocytes are then lost in the interstitial fluid and need to be removed. That is where they have the lymphatic drainage into a lymph node, bringing these lymphocytes with it there to the lymph node. Some leave the node through efferent lymphatics. They come together to form the thoracic duct, which goes into the caudal vena cava. The lymph is then back into circulation of the peripheral blood. Another way lymphatics are getting out, lymphocytes migrate through the endothelium. Then there's a concentration of antigens here, and they get out that way. Predominantly T cells are doing all this in circulation. B cells are short-lived and T cells are long-lived. Lymphocyte morphology, he just wants us to know that a normal cell lymphocyte is smaller than a neutrophil. We have all these other ones as well. So the normal one is this top one here, and these are different. So the left is immune response occurring. Not many are present, but they're usually bigger than the lymphocyte, the normal lymphocyte. In the middle, we have a bluer that have more polyribosomes. So these are ready to produce. This is an amniocyte. And then to the right, these are more typical in large animals. They're quite big, but they were quite rare. So the main causes of lymphocytosis are physiological, so excitement, epinephrine-induced, chronic inflammation, so that's antigenic stimulation, young animals, hypoadrenal cortisone, so Addison disease, and then lymphoneoplasia. So starting with physiological excitement, lymphocytosis, CBC findings that support this would be neutrophilia, erythrocytosis, and then thrombocytosis, which has to do with splenic contraction. Also, hyperglycemia is due to the epinephrine effects. So I talked about this yesterday, the physiological excitement, not of lymphocytosis. I think it was of white blood cells. But here we have increased cardio output from the adrenal medulla. And this is the fight or flight response, the most common in horses and cats. This moves lymphocytes from the marginal pole to the circulatory pore. It's hard to get into lymphatics, so they stay in the circulation. The thoracic duct empties, and this leaves them in the circulation. Hyperglycemia is due to epinephrine, and plasma proteins stay the same in this case. But then we have chronic inflammatory lymphocytosis. So the lymphoid hyperplasia, so in lymph nodes, in response to antigens, these cells produce T cells or immunoglobulins. This increased numbers in circulations, thus higher numbers of lymphocytes in circulation. The big cells here are amniocytes. So when you see amniocytes, you're going to think chronic inflammatory lymphocytosis. Also look for a left shift, neutrophilia, and toxicity. It means that the total proteins are increased. And also CBC findings that support this due to chronic inflammation is neutrophilia, the left shift, the toxic chains, monocytosis, and anemia of chronic inflammatory diseases. So we also have a pseudo-lymphocytosis or a young age. So this means fake because it's normal for young animals. So blood work could be weird, but it could be just normal for young animals. Okay, and then we have Addison's disease, where the cortex can be damaged. It has lack of cortisol production, so it's opposite of the stress process, so normal lymphocyte count. We have hyponatremia, which means low sodium. We have hyperkalemia, which is high potassium. And then we have lymphocytosis, which is the opposite of stress. But he said we didn't need to know much about Addison's disease because he's going to get that. We're going to get talked to about that later in our courses. We have neoplastic lymphocytosis. So in lymphoma, so stage 5 lymphoma, neoplastic proliferation of a clone of lymphocytes, so usually immediate to larger, arising outside of the bone marrow, so lymph nodes, spleen, thymus, and intestine. But for acute lymph node, lymphoblastic leukemia, we have a neoplastic proliferation of immature large lymphoid cells arising within the bone marrow. But for chronic lymphocytic leukemia, we have neoplastic proliferation of a clone of small lymphocytes arising within the bone marrow. So we have reactive inflammation versus neoplastic small lymphocytes, which is a table here. It just basically compares and contrasts everything I just told you. We can have neoplastic or reactive, which means inflammation, lymphocytosis. So severity higher or lower in reactive or neoplastic lymphocytosis. Well, we have a higher cell count in neoplasia, so neoplastic lymphocytosis. Lymphocyte morphology, the blasts are bad, so monomorphic favor neoplasia. Cytopenias, they also favor neoplastic. In physical examination, if there's weight loss, hepatosplenomegaly, multiple nodes enlarged, this also favors neoplasia. Lymphopenia has to do with stress and acute inflammation. Usually you see lymphopenia for viral, bacterial, and endotoxins. Under depletion, we have lymphoid infusion, so chylothorax, so that means white fluid, and then we have the loss of lymph, which is lymphoangioectasia. And then we have lymphoid hypoplasia, which is immunosuppressive drugs, radiation, biodestruction, and congenital. So that was the end of all our lectures today besides bacteriology. I'm losing my voice, so sorry about that. It's probably very hard to understand. The material is hard to understand as is. So thanks for hanging in there with me, guys. It's a bad week to get sick. So of course the one time I go out, I get sick. But I'm gonna work with it because we have 2 exams, so I have to push past it. But I hope you guys had a good day today. I think it's Tuesday now. I still have a lab to go to, so I'm gonna currently probably go do that in a little bit because that starts at 3. But I love you guys, and I hope you guys had a good day.